So with myeloma, you know, I've been in practice for 5 or 6 years since fellowship, and I mean the field's exploded. It's amazing how many new drug approvals we have, which is great for our patients. And I think now we're entering the era of immunotherapies in myeloma, specifically the CAR T cells and the bispecifics. And just to reiterate the difference, because these things are confusing even for physicians. So CAR T cells, as Dr. Rajeeve discussed, these are where patients, their own immune cells, their own T cells are collected from the patient. So it's a procedure, they got to collect them. They then send them to a lab where they're modified to attack the cancer cells. And then we have another class of therapeutics that work similarly, but are different, which are called bispecific antibodies. And there is now one approved just a few months ago now for myeloma called teclistamab, which is great for our patients. And this drug works by basically bringing the T cell, the patient's own immune cell, to the cancer cell. So it brings them together. It doesn't modify the T cell, brings them together. Both the CAR Ts and the bispecifics work really well in patients. So Dr. Rajeeve, how would you have a patient in front of you who, is in need of one of these therapies. What are some things that go through your mind in selecting CAR Ts versus bispecifics for the given patient in front of you?
Yeah, absolutely. I think, it also well, first of all, I think these are both very efficacious therapies, which in patients who have seen multiple lines of treatments we have at this time point. So when assessing whether a patient is a candidate for CAR T versus bispecifics, I think the institution's access to these medications would be a consideration, whether the patient's disease is like kind of behaving, whether it's stable versus if they need treatment right away. They may not be like, we may not have the time to collect their cells. We may not be able to effectively bridge them and then give the CAR T cells back. So in such a patient, especially with now commercial teclistamab available, I think I would be very, encouraged to use teclistamab for disease control. If someone is a patient, if someone's a candidate for CAR T, their disease is progressing, but the kinetics of the disease is not extremely rapidly explosive, I think that's a patient I would consider collecting, giving a cycle or two of bridging therapy, and giving back. It also depends on how I think the patient, by the time patients are eligible for CAR T or bispecific, their follow-ups and how they tend to be. Bispecifics tend to have like a continuous manner of infusion. CAR T is like a one and done, and you can give them like a nice window of treatment-free time. So access, their disease status, all of these will go into consideration, I would think.
Yeah, no, those are perfect points. And I think, like they both have we don't know what's better. They haven't been compared. Hopefully one day, maybe they will be. But at this point, we have no head-to-head comparisons of the two. So really, the CAR T, the pro, at least for me as a physician, especially who treats lots of myeloma, and if you have myeloma, you're on therapy for long periods of time, sometimes for years without treatment breaks. And the CAR T cell is a one and done therapy, although very intensive therapy, usually requiring a few days of hospitalization. But once you're done with the procedure, it can be years if you look at some of the data on our newest CAR Ts for that. Whereas teclistamab, the bispecific, it is something that is given continuously. At this point, we don't know yet if you can stop it. So that is something. And I think, even with the bispecifics, they're drugs that are not like CAR Ts, but I do think there's a learning curve to giving those drugs too. I'm spoiled, I'm at a cell therapy center and we do transplants. So we have all the infrastructure in place to deal with these types of therapies. So I think there's going to be a learning curve in the community. It's not that they're not capable, they just haven't done these things yet. And ideally what I see, I think best for patients who don't have immediate access to academic centers will probably be maybe starting a bispecific at an academic center, which is usually first round of the bispecific is usually where the most toxicity is. Actually, it's almost all of it is going to happen with that first or second dose, and then continuing the therapy outpatient with their local physician. I think, again, though, it's going to be a lot of communication, and hopefully we'll get better at this as we progress. So again, all hard things. And I think another thing with CAR T, in my opinion, is, you have to be well enough to get the CAR T and do well for a few months. We've got to cook the CAR T. It's not out of the package like the bispecific. So, even at our center, we're pretty fast. It can be a few months before a patient, they see me and I go, you need a CAR T cell. It's still going to be 8 weeks maybe till they actually get that CAR T cell. So for patients with explosive disease that need rapid treatment, it's not sometimes the best option. So these are things that physicians are thinking about when we're dealing with patients in our clinics being evaluated for these therapies. So it's great to have all these therapies, but it's making our job tougher. But it's good that it's tougher. So
That's a good one. Quick question about your practice. Do
Yes.
you ever think of like, or in the sense that like what are the costs that we are incurring for CAR T versus bispecifics? I mean, it's very hard to estimate, but then CAR T is again, you come, get admitted, get your CAR T, and then it's follow-up. But bispecifics, as of now, it's continuous when studies of like a definite therapy are only ongoing. So again, when choosing disease kinetics apart and other considerations apart, do you ever think of the financial implications? And also, would you ever move to like a completely outpatient administration?
Yeah, so we're so first, as far as costs, and costs are very important to me, but it's hard with the patient in front of you. It's hard to let cost be a factor when they need these therapies. And as of now, our process at UCSD is no patient's paying out of pocket for a CAR T. They don't make it that way through the approval, because if they no one can pay $500,000 for one of these things, which is, I believe, what it costs. And with teclistamab, I've so far prescribed it now once for my own patients. It just was approved, and again, it's mega expensive and the insurance is paying for it. So yeah, they may have a high deductible and they'll go through it pretty fast. So but again, that's just a sad state of where our cancer system is. Patients who need these therapies, they need these therapies, and they're willing to do, in most cases, what it takes. So and I think that physicians to figure out better ways to advocate for our patients and try to cut down costs and work on clinical studies that address these things.